be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone, and welcome to tonight's Lung Cancer Living Room, where we will be discussing women in lung cancer and disparities and solutions in diagnosis, treatments, and care. We are thrilled to have you. For those of you who are able to join us today, I'm Danielle Hicks, Chief Patient Officer here at GO2 Foundation for Lung Cancer. Tonight we have Melissa Johnson, MD, Director, Lung Cancer Research Program at Sarah Cannon Research Institute at Tennessee Oncology in Nashville, Tennessee. We are thrilled to have her here with us tonight. You may be asking why women in lung cancer, why are we making this a topic? And hopefully that becomes really clear to you by the end of this conversation. But lung cancer is the leading cause of cancer death among women in the United States, which I think is a shocking sort of fact for most folks. They don't really recognize or understand that. This hidden women's cancer is the least funded cancer in terms of research dollars per death of all the major cancers, and one of the only cancers where patients are routinely blamed as responsible for their condition. So we're going to talk a little bit about that and maybe some of the whys behind it, some of the hypotheses behind it, and what we think needs to be done and what we as a community can do for this condition. We're talking specifically about women tonight, as you know, because there has been an increase in women, specifically never smoking women, being diagnosed with lung cancer. Why do you think that is?
Well, first of all, probably most of our audience knows this, but in the lung cancer field, we define a never smoker as someone that smoked less than 100 cigarettes in their life. And we have seen an increase in lung cancers in never smokers, men and women, over the last few generations, actually. We also know now that women who are never smokers are 3 times as likely to develop lung cancer as men who are never smokers. And that's sobering. Even more sobering is worldwide, of all the women with lung cancer, 50% of them will be never smokers, as compared to only 15 to 20% of men. So there does seem to be something different about women. And so so what is it and why? I wish I had the answers. I guess the short answer is we don't really know. But there are a lot of theories about why. Some of them are the genetic alterations that I spoke about. EGFR is one of them. ALK, and ROS1 are 2 others. And we see those special types of lung cancer more commonly in women than men. So we think that there is something about their genetic makeup that may predispose to these oncogenic drivers and the lung cancers that they cause. That's a gender thing, but what about that's a sex thing. Hormones also relates to women. About between 45 and 70% of lung cancers will express estrogen receptor, and that's in men and women. But women have more estrogen sort of floating around, and so is that possibly a connection to why women have more lung cancers when they don't have cigarette smoking as a risk factor? It appears that women may be more biologically susceptible to the carcinogens that cause lung cancer, such as tobacco smoke. A 40-pack year smoker who's a woman has a 3 times greater likelihood of developing lung cancer than a man that smokes the same 40-pack years. And all of that is interesting. And those are all sort of sex or genetic biology, nature related reasons. But then you might also think about the nurture aspects, the gender, the things that make us women, the fact that we're home more. And so maybe more exposed to radon, which is another risk factor for lung cancer. The fact that women across the world are more likely to be the ones cooking, and in China and India at open, hot, coal burning stoves, that's a risk factor for lung cancer. And then finally, secondhand smoke, which is more common in the home. Um, may increase risk of not just lung cancer, of course, chronic pulmonary disease, heart disease, but both women and children are less able to negotiate a smoke free environment, especially in some other parts of the world. So that's a lot to say that we don't know. And so we clearly need more research as to what the real answer is.
Yeah, I think it's interesting. And I think you touched on a couple things that I'd like to expand on a little bit just to ensure that the folks watching understand. One is you talked about the genetic sort of correlation and or that women are more likely to have some of these biomarkers. Can you explain what a biomarker is?
Sure. A biomarker is a fancy term that tells us something about the cancer. And so, as largely see lung cancer patients in my clinic, and I will say to a patient, the biomarkers or the proteins that are expressed in your cancer are likely different from the guy or gal that's next door to you in the next room and the one on the other side. We could drill down a little bit further. It's not just what's expressed or what's different about a tumor at the microscopic level, but we are always looking for biomarkers that will predict response to therapy, and that's the key to the biomarkers that I've mentioned. EGFR is a mutation in the epidermal growth factor receptor. Um, ALK is a little bit of DNA that gets twisted upon itself and develops mutation between two pieces of DNA um, that weren't fused together before, for example. And we can find those biomarkers by looking at a patient's tumor tissue underneath the microscope, by doing sophisticated genetic or DNA analysis, and looking for biomarkers. If we find one, and we often do, 15 to 20% of the time we will, then that predicts that a particular cancer will shrink with a drug that inhibits that biomarker.
That's great. I appreciate you explaining that because, one of GoTo's goals is to ensure an increased rate of biomarker testing for patients when appropriate, and really being able to explain to patients who have been diagnosed but may not have had this type of testing, the importance of going back and talking to their physician about it to ensure, to your point, that if they do in fact have one of these markers, or what we like to say, these mutations that might be driving their cancer, when there is an appropriate or an approved targeted therapy, that may be the best treatment for this patient to be on. So we always want to make sure that we're touching on that.
I love biomarkers, and I would say, why wouldn't you test for biomarkers, right? If you're a cancer doctor, you would think that every doctor would know that, and I think most do. But the message that I want to make sure that our audience tonight understands is that it used to be that we checked for biomarkers in the tumor tissue. And so you had to have a biopsy that was adequate enough so that you could get the analysis done. And typically it's not done at all hospitals. It's a send out test. So your doctor, your oncologist has to be familiar with a lab that'll do it. These days, there are also ways to look for biomarkers in the blood. So even if you haven't had that testing because your biopsy didn't have adequate cancer cells in it in order to have that biomarker testing done, you can get the same information, or roughly the same information, from the bloodstream. So I saw a new lung cancer patient today, for example, who didn't have that testing ordered. I did order it on the tumor tissue, but I also did it in the bloodstream. And I think as we talk about access to care, as we talk about the different ways that doctors take care of patients, most oncologists understand that biomarker testing is standard of care frontline, but it's the tissue adequacy or it's the hospital rules that make it more difficult.
Such an important point in bringing up the ability to identify some of these biomarkers in the blood. And it's interesting because you'd be surprised, even whether through our helpline or in talking with folks, how many people aren't getting this biomarker testing up front, and it's disheartening, actually. So it's again one of the reasons it's so important to us that we have this conversation. So when we talk about these liquid biopsies, as we often refer to them as, being able to identify this in the blood, sometimes, and this is maybe taking us a little off track, but I think it's an important point to make. Docs are ordering the liquid biopsy alongside a tissue biopsy. Tissue biopsies are still technically sort of the gold standard. Can you talk a little bit about the differences in when you may or may not utilize a liquid biopsy versus a tissue biopsy?
As an oncologist, in particular, an oncologist who practices in the community, I have learned not to let the perfect be the enemy of the good, and plasma-based is an example of that. Tissue-based testing will always be the standard of care, or the gold standard, as you say, because there are alterations or DNA mistakes that you can only find in the tumor, or that are easier to detect in the tumor. These fusions or little twisted bits of DNA that get stuck together, they are easier to find in a tumor as opposed to in a blood assay. Deletions in parts of DNA can be harder to find in the blood as compared to the tumor tissue. However, ultimately, we need as much information as we can get about a patient's cancer. And really, up front, we want to make sure that if a patient is eligible for a targeted therapy, they receive that. And most of them can be accessed through the bloodstream. Now, if you have a never smoker, man or woman, and I can think of examples of both in my own practice, whose tissue was inadequate at baseline, who got plasma-based testing and it was negative, you can't stop there. Then you do need a second biopsy at some point in order to get the tumor tissue. And that's where I found the ALK rearrangement, the ROS1 rearrangement down the line in the care of patients. So it's not a one and done thing. I'll say that I use plasma-based testing in a serial way, which means that I may check one at diagnosis, and then after the patient's chemo and immune therapy, for example, is no longer working, I might check it again and see the resistant clones that have started to grow. That may give me ideas for clinical trials or help me detect alterations that weren't there before. Where tumor biopsies, obviously, doing repeated ones of those, while very scientific and in the right setting, a good idea for most patients is not a desirable thing.
Yeah, no, I couldn't agree more. And I'm glad you brought up the retest at progression, because I think that's also an important conversation for patients to be having with their physician. Is it true, and correct me if I'm wrong, that with one of these plasma or blood biopsies, if we find a biomarker or alteration, deletion, protein, any of those things in the blood, we know it's there? For example, there's a physician that we work with who always runs both in tandem, and the blood-based, testing comes back much faster than the tissue sample. So he always tries to run, when he can, both in tandem, because he says if he finds it in the blood, he doesn't have to wait for the tissue to come back to treat. But if you don't find it in the blood, that does not necessarily mean it's not there. It just means the tumor's not shedding this type of information into your bloodstream.
Yeah, that's the right way to think about it. Absolutely. So if it's
Okay.
there, you can trust it. It's not wrong. But if it's not there, it doesn't mean that it's not there. It means that the biomarker may have escaped detection by the assay.
That's great. And that I think was just another way of me to explain what you were already trying to say about maybe having to have another biopsy if you don't see it in the blood, and or if the original tissue sample was not sufficient for that. Why? And then I'll jump off the biomarker testing thing. But why might it be that a tissue sample was not reliable or couldn't be used for purposes of biomarker testing?
We can get a diagnosis of lung cancer from a bone biopsy, for example, but in order to use that DNA to do molecular testing, you have to denature it from the bone, and that gets rid of the DNA. So if you have an initial biopsy from a bone metastasis, that'll give you a diagnosis of lung cancer, but you can't use that biopsy for molecular profiling. Um, Sometimes it's really hard to get enough tissue. And in my world, where I try to treat all patients on clinical trials, sometimes we want to save the tumor tissue for a clinical trial opportunity. Um, or we have a clinical trial opportunity and we need tissue for that. And so those might be ways that you're trying to skin multiple cats with one biopsy sample. Wasn't exactly what you were asking, but that's what that
No,
makes me
no, I
think of.
think no, I think it makes sense. And sometimes maybe you just didn't get enough tissue or good quality tissue, and sometimes the tissue is what's called necrotic, and it's just no good. It's no bueno, right? And I know I said I was going to move on from biomarker testing, but I have one more question because again, it's so important to go to and to our lung cancer community that they really understand the purpose of this type of testing. There's a handful and a half or so of known targets within lung cancer. But there's also this sort of thought around doing this comprehensive testing. And you mentioned clinical trials, so I thought it was a good segue into the why behind comprehensive testing versus maybe just that, handful and a half or
Targeted.
so. Yeah.
Yeah, that's a really good question. That's a question I get from my colleagues a lot. Like, Melissa, why would I want to do broad testing? First of all, it's confusing to me, and I have to explain it to my patient. And second of all, we don't have drugs for the 600 genes in the panel.
Right.
But the truth is that we started off doing next generation sequencing testing, which is comprehensive molecular profiling, around 2008. And that was right around the time that uh, we knew about EGFR. We kind of knew about ALK, and that was about it. And so now we have ROS1 that came very quickly after ALK because those two alterations are very similar and can be treated with the same drugs. We now have BRAF. We now have KRAS, G12C, and that certainly is an example that where we've known about KRAS mutations in lung cancer for 30 years, but we hadn't achieved a therapy that worked. So these things are all works in progress. And while today, for example, we only have a drug for a KRAS G12C mutated cancer, I hope that the next time that you invite me to participate in one of these sessions, we'll have a KRAS G12D inhibitor, for example. And so if we don't look, we won't find these patients to put on the trial. And that will become FDA approved therapy. Sometimes we find that there's an alteration that we didn't think resulted in a functional change that later on we understand is very important. And so it used to be on the back page of the profile that's several pages long, and now it's on the front page. So we don't know what we don't know, I guess.
Yeah, I couldn't agree with you more. And I think, especially for those folks who may not have a target that has an approved therapy, they may have a target that's got a drug in trials that may actually be a really great potentially first line option for them, right? Depending upon what it looks like. And I couldn't agree with you more that in KRAS, that was a huge win for our lung cancer community because when you look at all the mutations, KRAS is sort of the biggest piece of the pie, right? And although there are submutations of KRAS, as you mentioned, G12C being the most recent one where a drug was approved, it's a huge win. So anyway, everybody,
I'll give you just one other example of I was on a call today for a clinical trial that's looking at a P53 mutation. P53
mhm,
mutations are the most common mutations in cancer, irrespective of type, so not just lung
mhm,
cancer. And this one mutation, Y220C, is they've developed a drug that targets that. And so, who would have ever thought? See, I
yeah.
can remember several years ago when we were thinking about that for the first time. And I thought, well, that'll be hard to find. Maybe another time I can tell you how we find those patients at Sarah Cannon through our molecular profiling software that helps us identify the right trial for the right patient.
I would love to have that conversation with you. And the last thing I'm going to touch on here is you mentioned some of your colleagues, even. I mean, these are folks who are treating, lung cancer patients, not really understanding the comprehensive and how do I explain it to my patients. And I just want to let patients know who are watching. We have a lung match team at GoTo that can help you as the patient kind of understand what that report looks like and what this means so you can go back and have an educated conversation with your physician about it. So don't forget to go to and lung match if you have any questions about that. So one of the next things, jumping back into the women piece of this for a minute, you mentioned estrogen, and I know that HER2 has been identified in lung cancer as well, right? And I also know, and I know we don't necessarily know the answer to this, but I'd love for you to talk about it a little bit. I've had experience over the last, 15 years or so of talking with patients, of meeting women who are diagnosed with breast cancer to be cured of that, only to later down the road be diagnosed with a secondary primary that is lung. Is there a correlation? Are there any studies going on there? What are your sort of thoughts on that?
Yeah, that's a really interesting question. The easy answer is that of the risk factors for lung cancer, prior radiation in the chest is a risk factor. And so, if you've had a breast cancer that required lumpectomy and radiation, for example, or required radiation at all, then that can be a risk factor. I don't think that it's as simple as that, unfortunately. But I think that that can be one way that the two are linked. You certainly can't fear, the next shoe dropping when your doctor's telling you what is recommended for the devil that's at the door. But
Yeah, no, I agree. And I think, again, it's a conversation with your physician, right? And as long as that conversation is happening and everybody's understanding um, the risks involved. I know we talk about it in the screening realm, and we talked about it for years before screening was approved for lung cancer because of that exposure potentially causing further harm or a different type of cancer. So radiation, we can have a whole living room on that one as well. One of the other
yeah,
things you talked about was radon, and I know there are maps that you can pull up online in organizations out there that focus specifically on radon. But can you talk a little bit about what that is as an exposure? Because I know there's a lot of people out there that don't know they might be living on top of it, and to test for it.
yeah, it is a good question that I probably need to know more about. But you're right. You can Google testing radon in my area. We can find radon in the walls of old houses. We can find it at construction sites, for example. And it is something that doesn't have a smell until it's just taking over your air, so you can
Hmm.
breathe it without knowing. And so that's why it's associated with lung cancer. The risk, though, just to be clear, is far, 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 far less than cigarette smoking, for example. That remains the most common cause of lung cancer today. And while our focus is never smokers and women who tend to be never smokers, cigarette smoking is still by far the most common cause.
Yeah, absolutely. Couldn't agree more. There are, though, for those of you interested in learning more about radon, heat maps out there. Radon comes up from the earth, and to Dr. Johnson's point, literally invades your air and your space and gets in your walls and your floors and all of that. And there are tests. Home Depot, you can go buy a test to see what type of exposure you may be living in, just in case, right? Um, so one of the other things you talked about were women being at home. I know that in the early days of EGFR, we primarily tested Asian women. And I think some of the early thinking around that was because of the cooking and the way that they tended to cook, particularly in the more rural areas, causing carcinogenic exposures. Women are also most likely to be the ones that are cleaning the house, right? And using all of these different, cleaning supplies and materials in closed spaces without proper air ventilation. Could there be a potential there for exposure?
If there is, it's less known, and it's not any one particular product. I think the cooking, the hot oil, breathing in from a coal fire or from an oil based stove, and sometimes, I mean, increasingly we talk about air pollution being the three sort of established exposures more than cleaning. Having said that, if you work in that sort of environment all the time, you probably do need to wear a mask. And in this day of N95s being as available as they are, there are a lot of places where we should be wearing them, probably occupationally, where we didn't think that was acceptable before. So I would say janitors, among them, anybody that works in and around cars, mechanics, that kind of thing. Um, Asbestos is another cause, and while shipyards aren't exactly a place where women and children are going a lot, that's another place where there's an exposure you can breathe in.
I think one of the other things we talked about were family connections, and is there potentially a familial tie to this? And I think all of what we were just talking about points back to research that has not been done, things that we don't know but we need to know, which sort of brings me to a shout out I want to give to Alchemy, the Adario Lung Cancer Medical Institute, which is a closely tied, we tend in-house to call it a sister organization to Go To Foundation. They're doing an epidemiology of young lungs cancer in this instance, but really taking a deep dive look, right? The we don't know refrain drives home how important continued investments in research are to better understand and treat lung cancer in women and other populations such as young lung cancer. This study seeks to help researchers and clinicians better understand why an increasing number of young people are developing lung cancer. Specifically, we're looking to study the environmental and childhood exposures or other risk factors such as family history for lung cancer in patients under the age of 40. It's a 200 question survey to capture that information on demographics, medical history, active and passive smoking history, early life exposures, residential and occupational history, menstrual and reproductive history, if applicable. Obviously, the men don't have to answer anything about that. Diet, physical activity. There's also an option to invite your birth mother or father to participate in the study. And in addition, you'll provide a small sample of blood that you'll be able to choose your own provider to collect. Or we can arrange for the sample to be collected at your home. So I think this is a really good example of doing a deep dive and collecting this information from enough people to kind of try to gauge and gain a better idea of where the research or more research should be done. I want to step back a little bit and talk about some disparities when it comes to women in lung cancer. Can you talk a little bit about what those are and why you think they might exist?
I think it really boils down to the fact that people don't think of lung cancer as a women's cancer. And that starts, unfortunately, with medical providers, right, who are sitting across from you in the examining room. And if you qualify for a lung cancer screen between the ages of 50 and 80 with a 20 pack year smoking history now, having quit within the last 15 years, you should be screened. And that doesn't come up as often as have you had your mammogram and when was your last pap smear. I think it's you said this at the outside of the show, Danielle, more women will die of um, lung cancer than breast cancer, ovarian, and uterine cancers combined. Yet women themselves aren't worried about lung cancer as much as they are the others. I read in preparing for tonight a survey that was conducted by the American Lung Association of women at risk for lung cancer for whatever reason. 1,000 women replied, and only 1% said they were concerned about their risk of lung cancer, where 2/3 were concerned about getting breast cancer. And only a quarter of patients had said that they'd talked to their primary care doctor about either one. And that to me was just sort of jaw dropping, that we can't just criticize everybody else, that it starts with us as women understanding that this is something that could affect us. It's not something that you think about, right? I think about the VA, or I did for a long time. And my dad was in the Marine Corps, so, and for 35 years, so I can say this. But the old men that get lung cancer are not the only demographic. And so we need to increase education amongst amongst the medical community, as well as empower women who meet the criteria for screening to ask for it. And then we probably need to figure out how to screen never smokers, because to the point that you made about risks of cancers, right now, the risk of radiation exposure for a never smoker is high enough so we can't screen them in the same way we can for patients that have a cigarette smoking history. So we got to figure out how to find them. I hope it's in the blood. I hope that one day it'll just take a drop of blood to screen, and that won't be invasive in the same way that a CT scan is. I dream about that because I think that would be great.
Yep, I could not agree with you more. Just sticking with the screening for a second, because I want to touch on a couple of things that you said. A absolutely general awareness, not only within the at-risk population, but within the healthcare community, primarily primary care physicians, um, um, OBGYNs, having these conversations. I know I go every year and have a conversation with my doctor about different screenings. You mentioned mammogram. When I turned 50, it was, now we're talking about colonoscopy. But nobody has ever asked me whether or not I am at risk or fit the guidelines for screening. And with that, I want to make sure that folks watching understand what those guidelines are. And you mentioned they just changed. So the USPSTF guidelines were just reduced, so it allows for more people to have access to screening. So it's
Or
folks between the
expanded,
ages of
really.
expanded, correct. Folks between the ages of 50 and 80, if you have a 20 pack year smoking history or greater, and by pack year, I think you guys have heard Dr. Johnson mention pack years a couple of different times. And what that means is a pack a day for that many years. So a 20 pack year smoking history. If you currently smoke or have quit within the last 15 years, you qualify under the new guidelines. We could not agree more that those guidelines need to be expanded, because right now they really do revolve around what a smoking history might look like. We're not going to look a gift horse in the mouth because we waited a long time to get screening, on the plate for even this subset of patients. But what I can tell you is that in this country alone, roughly 16 million people currently qualify for this screening. And sadly, only about 4% of that 16 million are actually going in and actively getting screening and proper follow-up when appropriate. So I encourage you to speak with your physicians about it. If you have questions about this qualifying criteria or whether or not you may or may not be at risk, you can always reach out to GoTo Foundation. Our helpline is staffed by incredible folks that work with me in the foundation that can answer any of those questions. So sorry, I just wanted to stop and touch on that a little bit before we kind of jump into what some of those other disparities may look like.
Well, just to add, and it sounds like your hotline, the people that staff your hotline would tell this, but it is under the Affordable Care Act, should be reimbursed by private insurance and is covered by Medicare. So that encompasses a lot of people, and you may now know that better than your doctor.
Yeah, absolutely, absolutely. So with that, let's jump into maybe some delays in diagnosis. Why do we think that may be?
So if you're not thinking about lung cancer as a possibility, then you're probably not talking to your doctor about a symptom. And I think for women, because lung cancer isn't something that you think about, you and your doctor might let a symptom go undiagnosed for longer. I think for the same reasons as a doctor is thinking about what to screen you for, trying to do their job, because the last thing I would ever want to do is criticize my colleagues who, for the most part, are just a hardworking group of people in the medical world that we live in today. Women are also less likely to be referred to smoking cessation programs. And even once diagnosed with cancer, this one's a big surprise to me, are less likely to be referred to palliative care programs. So what's the root of all of those? I'm not sure. But I wonder if some of it has to do with all the people that women are caring for besides themselves or before themselves. I typically, women are the caregivers. They're making sure that the kids get all of their doctor's appointments, and there just isn't time left in the week for yourself. They are trying to get their husbands or their partners to take care of themselves. There's not a whole lot of data to support that, but that's just my gut, Danielle.
Yeah, I could not agree more. Yet again, in what you're saying, those societal constructs really lend themselves to women's health just plain coming last, right? You can have the flu running through the house, and mom may have it too, but she's making sure that the kids are taken care of and that maybe her spouse is taken care of before she's actually reminding herself that, oh yes, I should probably take some time and rest and hydrate and do all those things I should be doing. So I could not agree with you more. You touched, Dr. Johnson, on palliative care. Can you talk a little bit about what that means? We just had this conversation in a different living room last week. I think there tends to be fear around palliative care, specifically because I think folks associate that with hospice or end of life care. Can you talk a little bit about the supportive care that this palliative care provides?
In fact, today, I told you I'd met a lady with a new diagnosis of lung cancer. We talked about palliative care already at her first visit, not because there was anything in particular about her case, but because I explain it as taking care of the patient. And that goes hand in hand with taking care of the cancer. We actually have a randomized trial to show us that early palliative care prolongs survival for patients with lung cancer, and that's from diagnosis. Um, Palliative care means paying attention to the pain that you might be having, paying attention to the constipation that the narcotics cause, paying attention to the fact that you're not eating, paying attention to the fact that this reactive depression has persisted, and you're having trouble focusing on the positive rather than the negative. Palliative care is preparing for the future, perhaps discussing goals and hopes for the future, but probably also preparing at the appropriate time for the worst so you can focus instead on hoping for the best. And all of that takes a while. And so from the very beginning, there's lots to talk about. And the truth is, on clinical trial or with standard of care treatment, the better the supportive care is, the better a patient tolerates treatment. And so the more successful they're going to be. So it is really true, Danielle, that there is a stigma associated with palliative care that makes my patients sometimes look at me like, no, no, Dr. Johnson, we're not doing
Yeah.
that.
Yeah.
I really actually have most of my patients also seeing a palliative provider concurrent with our visits. And, the palliative nurse practitioners in my practice anyway do a lot over telemedicine. That's one change that's not going back in the genie bottle for us. A really good use of that technology for sure.
I love that. And I think really demystifying palliative care and what it means and treating the whole person, folks understanding that your medical oncologist and the rest of, your radiation oncologist or so on are taking care of your cancer, but it's the palliative care team's job to take care of the rest of the stuff, right? So whether it's side effects, helping you with depression issues, as you mentioned, and I think a lot of times folks will not want to share with their treating physicians or their palliative care team side effects they might be having for fear of that, meaning they're going to have to come off of the treatment that they're on, when in reality it's hoping to get you to a place where it's not so bad that ultimately is what has to happen. So we've talked about some of the disparities just in general. Do you think that some of what we're talking about might be more prevalent in vulnerable and underserved populations, such as Black, Latino, Asian?
That's a really good question because it turns out that sex-based disparities may be even more exaggerated in some racial and ethnic populations. For example, Black women tend to smoke less than white women, yet their rates of lung cancer incidence are equal. So it seems as though the cancers they get um, are a little bit more virulent. That's also true in breast cancer. And it doesn't necessarily correlate with delays in diagnosis or decreased access to care. Secondhand smoke, interestingly, is reported in over half of non-Hispanic Black women, compared to about 30% of Latino women and non-Latino white women. And so that's another interesting statistic that I don't know how to unpack further, but there does seem to be yet some susceptibilities that differ by race and ethnicity. By contrast, I found a study of 2,000 Spanish women with lung cancer. 40% of the never smokers had EGFR mutations, so a higher percentage than the 10 to 15 to 20% that we think of. And 1/3 of those Spanish women reported secondhand smoke. So it does seem to it does vary, and the extent to which a female sex-based risk factor and a gender-based risk factor probably also folds in with a cultural, racial, ethnic differences, making it all the more complicated to separate.
Yeah, it's fascinating. And yet again, one of those sort of unknowns, and further research and funding
That
is the
need
only
to be
thing that's going to
understood.
get us there, right? And folks participating in these trials and studies to better understand what some of these differences are, which I think kind of brings us, to what are some sort of solutions. And I'd love to hear from folks that might be watching what maybe some of their thoughts are on this. And I'm really hoping that everyone heard Dr. Johnson talk statistically about mortality rates of lung cancer and how lung cancer takes more women's lives every year than the top 3 other women's cancers combined. That's a huge statistic. There's a lot of awareness that needs to happen about that, around that. We talked a little bit about why, some of these delays in treatment and women being the ones, tending to be caring for others and empowering others to get care, but not themselves. So one of the obvious things is take care of yourself, right? What else do we think that women could be doing to help us kind of get out of this place where we are losing more women's lives every year?
Maybe I'll start,
Hmm.
and then I would love to hear from the audience as well,
Yeah.
to the extent that it's possible. If we think about women and men just for a minute, lung cancer will kill 3 times as many people as any other form of cancer. We cure 90+% of breast cancers every year. We cure 99% of prostate cancers every year. We cure around 70% of colorectal cancer patients every year. And yet, there are more dollars in research funding for all 3 of those cancers than lung cancers, despite the depressing statistics that I shared with you. We need we need more awareness about the need for research. We need more people to give to alchemy, so that young patients with lung cancer, we can understand that as a population at risk. We need people to give to the Go To Foundation and other lung cancer advocacy organizations, so that we can fund research. We need pharmaceutical companies to understand that the difference in risk for never smokers, and the fact that their cancers are different than a patient who has smoked 30 pack years. Um, I think that awareness is at the core of a lot of what we need.
I couldn't agree with you more. And I'm going to yet again reiterate, because I cannot drive this home enough, understanding your risk. We went over the qualifying criteria for screening. If you think you fit that criteria, have a conversation with your doctor. Also, understanding symptoms, I think, would be, another important thing, and what to look out for. Sadly, symptoms don't usually rear their ugly head until you are at a later stage. So really, being able to identify, understand symptoms of lung cancer, understand what the screening guidelines are, pay attention, and take care of yourself. You talked about this awareness, and women. We look at the breast cancer movement, and breast cancer survival wasn't always at 90%, right? But women were leading the charge, right? They were the ones that were making noise about the
Yeah.
injustice behind early statistics around survival. So becoming an advocate, and participating in legislative efforts. Go To Foundation, for example. I want to talk to you a little bit about our Women in Lung Cancer Research and Preventative Service Act of 2021, which is Senate 699 and House 1800, which draws an urgently needed bright light on disparate impact lung cancer has on women. This legislation directs the Secretary of Health and Human Services, in consultation with the Secretary of Defense and Secretary of Veterans Affairs. Dr. Johnson talked a little bit about veterans earlier, to conduct an interagency review to evaluate the status of and identify opportunities related to increased research on women and lung cancer, so dollars, improved access to lung cancer preventative services, and launch of a national public awareness and education campaign on lung cancer. If we can amplify our efforts and make our voices heard, women and men, to raise awareness, together we can demonstrate the strong commitment we have for positive change in this lung cancer community. We too can be at 90%. And I think the screening is sort of this low-hanging fruit for us to help move that needle forward in the survival rate for lung cancer patients. A statement was just made yesterday by the Go To Foundation for Lung Cancer and was submitted for record. to the House Energy and Commerce Subcommittee on Health Committee, providing written testimony to give thanks for leadership and in support of HR 3749, which is Catherine's Law for Lung Cancer Early Detection and Survival Act of 2021. This points back a little bit to what you were talking about, Dr. Johnson, is how can we expand the screening criteria to get more folks in. We're working directly with former Congressman Rick Nolan, Congressman Brendan Boyle, Senator Tina Smith, and our scientific leadership. We've contributed to the recent language in Catherine's Law to help enact legislation that would raise the necessary support to develop better early detection for younger women at risk for lung cancer. We know all too well, we've talked about this ad nauseum during this meeting, that early detection can save lives and lead to effective long-term treatment options. The legislation honors the memory of Catherine Benson, who was Congressman Rick Nolan's daughter, who passed from this disease in 2020, shortly after attending our annual advocacy summit, where she advocated to Congress for herself and the countless other lives. So there are multiple ways for women and men to get involved and help raise the roof and make some noise and generate awareness on this. And I think a lot of it starts with educating yourself on this disease, on the risk factors, not just for you, but for your neighbors and your parents, your moms and your sisters and your friends and your children. Really getting a better grasp on what this disease really looks like and what it means, and getting out there and advocating for yourself and others. So we are so thrilled. Melissa, thank you so much for joining us. We're thrilled that you're taking something away from this, as well as the folks that are watching live and those that will come back and watch post live. Before I give thanks to our supporters, I do want to give a shout out to this lady, who I mentioned could not be here tonight. And her book, Hope, The Living Room, A Lung Cancer Community of Courage. It tells the stories of multiple different people living with lung cancer. So if you don't have a copy of this book, you can also reach out to gotofoundation.org and we can make sure to get one in your hands. Or of course, you can check it out on amazon.com. But thank you, most importantly, all for watching tonight. A huge thank you to Dr. Johnson for coming and having this really, what I think is a great conversation, to Peninsula Television, who is on the back end of this, helping to bring this to you seamlessly every month. And of course, I'd be remiss in not thanking the GoTo Foundation for Lung Cancer team as a whole for working as tirelessly as they do every day. We all, of course, could not do this without our generous supporters. So a big thank you to Amgen, AstraZeneca, Bristol Myers Squibb, Daiichi Sankyo, Foundation Medicine, Genentech, Lilly, Merck, Novartis, Regeneron, Sanofi, and Takeda. That's a really long list and a mouthful, but it really points back to our industry partners and how important and invaluable they feel that this program is, as well. So thank you, everyone. Until next time, we'll see you.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.